Namaste everyone. Welcome to the third PNB knee course pre-conference online discussion. My presentation is on implants used in arthroscopy. I am myself Dr. Sajendra Kumar Dual from Nepal Armed Police Force Hospital. My moderators are Dr. Rupesh Baide and Dr. Sailaj Ranjitkar. Graft fixation is one of the important surgical factors for functional and anatomical restoration of graft. The fixation device play a vital role in this step. It is very important to know the exact time to healing of different grafts. The biological incorporation of bone-to-bone graft takes place at 6 weeks. Soft tissue to bone healing occurs at 12 weeks and allograft it takes 18 weeks. So during this early healing phase, there is more chance of failure of fixation device rather than the graft failure. The force experienced during the early post-operative phase are ground level ambulation 303 Newton, downhill walking 445 Newton, and early rehabilitation 590 Newton. Nowadays, in practice, we are in era of accelerated rehabilitation. The implant must withstand all these stresses and provide stable fixation. Ideal fixation device must be strong, stiff, and secure. Strong enough to avoid failure against load, stiff enough to restore stability of knee, and secure enough to avoid slippage. The ideal fixation device must provide anatomical fixation, biocompatible, MRI compatible, should be safe, reproducible, and easy revision, as well as low cost in our context. So when we are talking of ACL fixation system, it is implantless and implant. Coming to implant, it is aperture fixation or suspensory fixation. In aperture fixation, interference screws are popular, and in suspensory fixation, it is either cortical fixation or cancellous fixation. What is aperture fixation? It is fixation done near the anatomic origin adjacent to the articular surface. Interference screws are widely used in this type of fixation. What is interference? It is the amount by which the diameter of the screws exceeds the gap between the graft and the tunnel. There are metallic and biodegradable interference screws. Titanium is preferred over the stainless steel implants as there is formation of bone over the titanium implants while there is formation of fibrous tissue over stainless steel implants. When we use the metallic screws, it should be different for the femur as well as tibia. For femur it should be small diameter and the articular end must be round, while in tibia the articular end must be flat. In biodegradable, there are various generations of bioimplants like polyglycolic acid, polylevulactic acid, and polyether ether ketone. Peak was thought to be a biodegradable, but it is not a biodegradable, it is actually a bioinert implant. Factors that influence the initial tensile properties of interference screw in bone patellar tendon bone fixation are screw diameter, gap size, screw length, and screw divergence. Increase in screw diameter increases the fixation. Gap size is one of the critical factors in interference screw. It is the gap between the bony block and bone tunnel wall. Gap size is also one factor that can easily be measured intraoperatively and controlled by surgeon. Improvement in initial graft fixation can be achieved by increasing the diameter of screw to compensate for the gap size. Screw length does not have large influence on the initial fixation properties as the length of the bone block is limited. Screw divergence less than 30 degree does not seem to have significant effect on clinical outcome. The screws should be placed parallel to the bone block and bony tunnel. Factors contributing to the initial fixation properties of soft tissue graft fixation are screw geometry, tendon fit, tunnel impaction or dilation, and screw placement. Screw geometry. Unlike interference screw fixation of bone tendon bone graft, screw length seems to have a greater effect on the initial fixation properties of soft tissue graft fixed with interference screws. Screw length has a greater influence on tibial fixation properties as the bone density is low on proximal tibia. Tendon feet. Feet of soft tissue graft in the bone tunnel appears to have a significant influence on the initial fixation properties of interference screw. So the graft should be snugly fit in the bony tunnel. Tunnel impaction or dilatation. Because the bone density has such a significant effect on the initial tensile properties of interference screw fixation, compaction drilling or bone tunnel dilation has been proposed as the method of creating increased bone density along the bone tunnel wall. Screw placement. Controversy exists regarding the placement of tibial interference screws. The interference screw may be fixed by inserting the screw on the side that is eccentric or down the center of the graft strands. Concentric screw placement maximizes the contact between the graft strand and the bone tunnel wall, providing a greater surface area of healing. As the world is shifting from a BTB to soft tissue graft, there is the evolution of bioimplants. PGA polyglycolic acid. It is the first generation of biodegradable polymers. It is hydrophilic and degrades in 3 to 6 months. It is so rapidly reabsorbed even before the incorporation of graft inside the tunnel, causing loss of fixation and a recurrence of instability. Marked inflammatory response like foreign body reaction, synovitis, and effusion are frequently reported. PLLA. It is polylipolactic acid. It has a good strength and long degradation period, 2 to 5 years. It has very good strength of fixation. It slowly reabsorbs and it has a complication like tunnel enlargement, osteolysis and cyst formation. Coming to PIC, it is polyether ether ketone. It is a dense plastic and it doesn't degrade. It is not a biodegradable. What is a PIC? It is a bioinert polymer, rigid, organic semicrystalline, thermoplastic polymer. It has high resistance to steam and chemicals as well as thermal degradation. It offers the advantage of good stable fixation and ease of post-operative imaging while not having any complication associated with polymer degradation. It is also used in aerospace parts, pumps, bulbs and semiconductors. Commercially, it is also available with the sheath so that the screw can be placed in the center of graft without lacerating the soft tissue strands. Biocomposite screws are latest addition to the biodegradable implants. These are made from biodegradable polymers reinforced with an osteoconductive bioceramics. They possess properties of both material strength and stiffness of both material. The calcium salt buffers the released acid from the polymer and helps osseointegration. The first generation biocomposite screws were any materials with tricalcium phosphate or hydroxyapatite with PLLA, and these are most on market. Second generation, these are stereoisomers and copolymers and faster absorption than PLLA. The reason for addition of new bioceramic materials as reinforcement agent is to promote and sustain bone ingrowth so that gradually the newly formed bone will replace the screw as they undergo the resorption process. The commercially available bioceramics are bitricalcium phosphate, calcium sulfate, calcium carbonate, and hydroxyapatite. Beta-tricalcium phosphate and hydroxyapatite are most commonly used. Beta-tricalcium phosphate is the most osteoconductive as it is amorphous material and gets quickly absorbed. This was the comparison study done in year 2013 Comparing a metallic or biaxial interference screw for graft fixation in ACL reconstruction. The final data outcome showed no significant difference in the final patient outcome in terms of clinical score, clinical evaluation, and imaging. This is the another study done in year 2016 comprising of 944 patients comparing the bioabsorbable versus metal screw for the graft fixation in ACL. They concluded that there is no difference between two types of screw in level of activity at 1 and 2 years. Now coming to the suspensory fixation, it is a fixation done away from the anatomic origin. It has gained popularity because of the soft tissue graft and anatomic position of the femoral tunnel. It is simpler, straightforward, and has fewer intraoperative complications than other fixation types. The principles are rigid fixation, no slippage, and it permits early rehabilitation. The type of suspensory fixation are cortical and cancellous. In cortical, buttons, staples, washer spike, and screw posts are widely used. In cancellous, crosspins. The crosspins are bioabsorbable as well as titanium. It crosses the graft at the cancellous bone. There is a more intraoperative complication as well as breakage of the implant. So this cancellous fixation is less popular in our part of world. The biological advantage of suspensory fixation is longer tunnel, circumferential healing of all sides of the graft, and the mechanical advantages are it grips the cortical bone instead of cancellous bone, so it's 30 times more stronger than the cancellous bone. The suspensory fixation are widely used during soft tissue graft fixation, posterior wall blowout, revision ACL, and backup fixation to the interference screws. Cortical suspensory fixation. There are two types, fixed and adjustable loop. These devices consist of a small oval titanium implant that anchors the graft against the outer femoral cortex. The implant is preloaded with a green and a white suture. The green suture is used as a utility suture or flipping suture, and a white strip suture acts as a leading suture. In a fixed loop, it's a standard implant with fabric loops with a 5 mm increment in size. In adjustable loop, it is preloaded with a non-absorbable suture which acts as a loop and can be adjusted. Fixed loop, it is reliable and consistent. It has proven clinically efficacy over 15 years. Adjustable loop, one size fits all. There is no need for overdrilling the femoral socket, and there is option of retightening after fixation. In fixed loop, the insertional length is overdrilled by 10 mm so that the implant can be flipped. The connection span is the loop size to be used. In adjustable loop, we only need to drill insertional tunnel with the desired of length of graft to be inserted. Graft is subjected to different kind of motion after suspensory cortical fixation. Bungee effect. When the graft moves up and down, it is a bungee cord effect. Windshield wiper effect. It is a sagittal graft motion, and creep is elongation of the graft after fixation. This is an article published in year 2014. It was a study done for the comparison of fixed length loop device versus the adjustable length loop device in ACL reconstruction, and the result shows that there is no statistical difference in the displacement among the endobutton groups and the tightrope groups. The world is divided into suspenders, compressors using interference screws, and hybrid fixators. So clinical outcomes of various devices are comparable. Basically, it is what works best in your hand one should do. Thank you Amit sir for giving me this opportunity. Hope to have active participation from all the delegates and faculty members. Thank you very much.